Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is dermatomyositis, part of our rheumatology revision series. So what is dermatomyositis? It's an idiopathic inflammatory myositis, just as polymyositis was in the previous episode. So this one is characterised by symmetrical proximal muscle weakness, which can develop over weeks to months, but this one is associated with a characteristic skin change, and these may precede the weakness. It affects approximately 2 per 100,000 people, with a peak incidence at 50 to 60 years of age. There's a female predominance of 2 to 1 and a slight increase in African American populations. So the clinical features are quite varied. At the core of it, there is symmetrical proximal muscle weakness developing over weeks to months, and this can affect the neck, the shoulders, trunk, hips, thighs, and indeed other muscles as well. There are characteristic skin changes which can predate the muscle weakness. Some signs to look out for, either in your PACES exam or mentioned in MCQ questions, firstly are Gottron's papules. So these are erythematous papules over the extensor aspects of the finger joints. Next are heliotrope rashes. So these are erythematous rashes associated with swelling over the eyelids. And a shawl sign, which is a macular rash over the back of the neck and across the shoulders. Just as polymyositis, you can get other clinical features with dermatomyositis. These can include arthralgia, interstitial lung disease, which can affect up to 80% depending on the population that's being studied, cardiac involvement, gastrointestinal involvement, which commonly presents as dysphagia if present. And crucially with dermatomyositis, it can be associated with an underlying malignancy that may have been undetected until the patient presents with the weakness and the rash. It's much more common in dermatomyositis than polymyositis for this to happen. And whilst it may be associated with any cancer, the commoner ones are breast, lung, ovarian and pancreatic. The investigations for dermatomyositis are similar to those for polymyositis and indeed for wider connective tissue disease. So the ESR may be elevated in 50% of patients. The CRP is really non-specific. You are likely to get elevated serum muscle enzymes, particularly an elevated creatinine kinase, but you may also see rises in AST, ALT and LDH levels. The specific myositis antibody for dermatomyositis is anti-My2. There are plenty of other antibodies associated with dermatomyositis, but really for the purposes of MRCP, that's the most common one that they're likely to ask you about. Further investigations may involve a muscle biopsy, and in dermatomyositis, this would show a perifascicular and vessel inflammation. Electromyography is also helpful, and this is abnormal in up to 90% of patients. And finally, an MRI scan of the muscles, for example the thighs, can identify muscle edema associated with inflammation. As we've discussed previously, dermatomyositis may be associated with malignancy, and this should be really considered in all patients with a new diagnosis of dermatomyositis. It's especially important if the patient is positive for two particular antibodies, which are TIF1 gamma and NXP2. You should also have a higher suspicion if there are certain risk factors present, for example, older age, male patients, dysphagia, and a rapid disease onset. So this is something to think about in MCQ vignettes or perhaps when taking a history in PACES, or indeed during a Station 5 examination. These patients therefore may require a CT scan of the thorax, abdomen and pelvis, and relevant tumour markers, and indeed PET scanning as well if the initial investigations don't yield any results. Dermatomyositis does associate with a high morbidity and mortality. The mortality increases in the presence of malignancy, as one may expect. Muscle strength and function can change slowly with treatment, as well as disease progression. The prognosis is worse with increased age, as well as when there is bulbar and cardiopulmonary involvement, just as was seen in polymyositis. The management of dermatomyositis is varied and depends on the symptoms present, but steroids remain the mainstay of therapy, and at least 90% of patients will respond at least partially to this. DMARD treatment can include methotrexate and azathioprine. IVIG is also helpful, as well as cyclophosphamide and rituximab in severe or refractory cases. Exercise programs are useful in the long term to improve fatigue and muscle strength. And of course, it does involve an MDT approach, and where there is specific organ involvement, then that particular team should be involved. For example, if there's GI involvement or cardiopulmonary involvement. And of course, if malignancy is discovered, then treatment is also required for that as well. So now if we go on to some questions. Question 1. A 50-year-old gentleman presents with 2-month history of rapidly progressive symmetrical proximal muscle weakness. He has a rash over his arms with erythema and swelling around the eyes. He has lost approximately 2 stone in weight in the same period and has noticed some shortness of breath. He is a smoker of 25 years, smoking 15 cigarettes per day. Blood tests show a new anemia, raised ESR and CRP, raised adjusted calcium and a CK level of 20,000. He's also noted to be ANA positive. A myositis screen is done and it comes back positive for anti-TIF1 gamma. So what is the next most appropriate investigation? So this is a vignette with a lot of information. This gentleman has a smoking history that's quite extensive, and he's presenting with a myriad of symptoms, including weakness in the muscles, a rash over his arms, and this erythema and swelling around the eyes. And if you look back at the slides, you may feel that this may be consistent with a heliotrope rash. He's also had some weight loss and he is short of breath, and several of his blood tests are abnormal, particularly that CK level. You'll also notice that he's got antibody positivity for TIF1 gamma. So we have a few options here. They are chest x-ray, PET CT scan, colonoscopy, ultrasound scan of the hands, and a skin biopsy. Now, of course, we would want a little bit more information, such as a fuller history, and to examine the patient. And depending on what we may find, all of these tests may be relevant at some stage. So patients may undergo a skin biopsy for their rash in dermatomyositis. If the patient is complaining of bowel symptoms, along with his weight loss and abdominal pain, then a colonoscopy may be prudent. If he's got arthritis or joint swelling on examination or on his wider history, then an ultrasound scan of the hands may also be helpful. And indeed, a lot of these patients do undergo PET CT scanning at some point. We can see from the history that he does have a TIF1 gamma positive dermatomyositis. So what we really need to exclude here is some form of malignancy. And given his smoking history and that new shortness of breath, the most important thing to do immediately would be a chest x-ray to exclude this. But as I say, some of these other tests particularly may be needed in the future, but in the immediate setting, the chest x-ray is most important. Question 2. A 30-year-old lady is given a new diagnosis of dermatomyositis after presenting to the rheumatologist with profound muscle weakness and a rash over her knuckles. ANA is positive. Which of the following other antibodies is most specific to this diagnosis? So we can see that she's presenting with dermatomyositis, and that rash that's described is possibly the Guttrun's papules. She's ANA positive, but she also has something positive quite likely on her myositis screen. So let's look at the options. Our options are rheumatoid factor, anti-CCP antibodies, ANCA, anti-MY2 and anti-parietal cell. So you'll remember from the previous slide that anti-MY2 antibodies are most specific for dermatomyositis. There are many antibodies that may be associated with dermatomyositis, as we discussed, but the most common for this rare condition is anti-MY2 and the one that's most likely to be asked about. We have heard about some of these other antibodies in previous episodes, and we'll be discussing some of them in future ones as well. So thank you for listening to this episode of Bite-Sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you'd like to hear from us in the future, and we'll see you in our next episode.